So here are the numbers. Among diabetic patients, the percentage with blood pressure less than 140/90 among our 18,000 patients, 90%. A1C is less than 8, about 82%. LDL less than 100, looks like about 73%. For vascular disease patients, blood pressure less, this is a tougher standard, blood pressure less than 130/80, 78%. LDL less than 100, looks like about 77%. And just for the plain hypertensive patient without vascular disease or diabetes, blood pressure less than 140/90 is about 78%. So,
Awesome.
Yeah. And that's hard when you're in. The kind of amazing thing is within our group there were certain clinics that were 10 or 20 docs that did better than this. So this is the average of 600. So there's some really, really outstanding ones. And one it's worth noting in Litchfield, Minnesota, which is kind of a small town, about an hour and a half away from Twin Cities, with 28% Medicaid patients. They were the highest.
They were in the best control?
What's that?
They were in the best control?
Yeah, they were one of the leaders in control.
And how? How did you do it?
Homogeneous community,
Uh,
education level.
Well, no, it's about 28% Medicaid and the crash farming.
So what's related to the patient population?
Well, it shows what you can do. You did say one thing about a cohesive patient population. When you see them in the supermarket, that's a lot different than when you send them off on bus line 7 and they go over. So it's a different thing. And all, but I would argue that it's the doctors that do it, the staff. So anyway, so let me go through and talk to you. I split this talk into two parts. One is just as I thought back on it, what were the specifics? What was sort of a recipe or the tips and tricks that we did that seemed to pay off? And then at the end, I'm going to talk about leadership. I think that's it. No matter what your game plan is, if you have the leadership, then you can make almost any plan work, even a plan that's just okay. We took someone else's plan, doing it basically. So here's some of the ideas. So tools, policies, and workflows. That's what we're talking about first. So leadership will be second. Idea number one is, and this is, I will turn this around so you can see it. This, all those blue bars that you can see there, those are clinics. So just as you all share data between yourselves, within your groups, do you share data? So that was a big motivator. So once we got the data out there, it had individual offices lined up. And so Litchfield is on the far left. They are, well, that's a couple of years old, but they were like 10% better than everyone. 10% better than the average, and 20 or 30% better than the people on the average.
Did you present your data blinded or unblinded? Presented inside.
Great question. It was unblinded at the office. So everyone saw where everyone was. The doctor saw it, the nurses saw it, the staff saw it, and everyone saw it. So that's number one. So idea number one, present group feedback transparently. Then the other thing, which I have here on the screen, a picture of a report that shows doctor name, doctor name, doctor name, doctor name, doctor name, and then the control of each of the risk factors, and then their overall percent control in the one. So that was by office or by clinic. So what they would do is they would sit down and they would see their own. So it was transparency. And we couldn't get there in the beginning. So first we had clinics and they were blinded. And then we had clinics with their names revealed. And then we had, within a clinic, doctors' names. First, within a clinic, the names were blank, the results were blank. And then it was within a clinic, all the doctors' names, the number of patients they had, and their success factors. So that, again.
How do you deal with the variability from the small numbers?
That's a great question. I guess what we did is, well, let me take that up a minute, because we had a lot of trouble in the beginning, and still do, where I am now in Milwaukee, we have a lot of trouble with, it's all about the numbers. I'm getting dinged. It's too variable. You know, I have a small panel, you know, I have 20 diabetics, and 2 are out of whack, and I'm toast. We had a lot of problems with that. But I think the answer is to not focus on the numbers so much. Oh, okay, there we go. It's not for everybody. It's better than it was. You know? Did you get any bigger? Does it,
Yeah, if I wanted to put it further away, I could do that.
Bruce, maybe set it in front of you.
If you moved it
Set it in front of you.
you here, to get it back a little bit further, if you don't mind us moving your lunch.
I do pretty much anything at this point.
I get to giving the coffee.
Oh, hey. Yeah,
That's good.
takes a bill. Chief resident, right?
Huh?
Chief resident, that's always
In another life.
Anyway, okay, so there you can see it. And, so sorry for you all that. In fact, you might want. Can you all see it now? You want to come around? You okay? So anyway, the answer to the question is, it will sort of reveal itself. But I think the answer is trying to get them to not focus on the numbers so much. Focus on the patients, and we'll talk about some ideas on how to do that. So that was it. The provider.
Did you meet much resistance in coming around with provider-specific information?
We met with some resistance. Different clinics could go at different paces, and it depended not on me, you know, the chief medical officer. It depended on the local leaders, and how fast they could bring their group. And the ones that couldn't bring their group very fast got courage from the others and said, well, no, like everyone else is doing, I think I need to. Provide patient-level data that can be verified. That's the third idea. You can't really see this, but through the EMR, and take the data out and massage it a bit, and we came up with reports. And this was key for us, that the data, it just wasn't, we weren't getting anywhere. And if you saw that curve going up from 2006 to 2010, you'd say, well, I got there in 2003. Well, what happened between 2003 and 2006? Not a lot. I got to be honest with you, not a lot. And because we didn't really have the data, and it wasn't enough to say globally, here's where Alina is, it just wasn't moving anybody. Even when we got numbers down to here's the clinic, it wasn't moving anybody. It wasn't until you could drill down and say, hey, that's really my patient, or that's not my patient, that people actually started paying attention to it. And this was critical because this is the lever on some of the tips I'll give about how we improve the diabetes care, but even more so, it gave credibility to the numbers, where people would say, okay, yeah, I'll buy that. Also, it also shifted the conversation from 29% to patient C. And that's the answer to how do you deal with a small panel. Say, look, I know you have a small panel. I don't really care about the numbers, but if we looked at your list, you know, if we looked inside the chart, would you find any that we could help more? And the answer was always yes. Almost always yes. Especially early on, it was yes, 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 yes. So here's a little one, and I don't know, I've been interested in anyone's doing this. Getting patients back in is key to getting better diabetes care, vascular care, and what have you, which is all the more challenging now in today's economy. But getting them back in is important. This we debated a lot in many different venues, whether we would not give refills unless patients came back in. Is anyone doing that now? Someone doing that? So it was very hard, because it was very hard to get people to that stage, because a lot of them would say, oh, they can't afford it, they won't come in, I at least want them to have their medicines. And in some cases, you know, maybe that's true, but in the vast majority, they were prioritizing this against other things they were spending money on. And once we, quote, forced them in, they got better care, and they had fewer heart attacks and strokes and fewer dying.
So when you implemented this, did you measure patient satisfaction? You know, I mean, only because there are some people, you know, that it might have affected your patient satisfaction.
Yeah, I don't know on that subset, but I can tell you our patient sat scores went up and up and up and up and up. So steadily, not like actually Charlotte's a great story. I don't know if everyone's heard it, but they kind of went like this. We're not. We were every year 2% more well deaths.
And to be clear, as a reward, if you're in control, you can get your refills without coming in, or nobody gets a refill without coming in?
No, we just figured good care was a visit at least every 6 months, even if you're in control. And you'd say, well, that's not always true. You have maybe I don't know, a diet control. Well, that wouldn't quite work. Someone on metformin who's running marathons and doing great things. The provider, they had the chance to override it. Our trouble actually was the other way, where the provider or the doctor would override it, and that wasn't the right thing. You'd have Dr. Nice Guy being a nice guy, and then his patients were dying. We had to actually show some examples where that really happened.
My question was actually related to that, because we've flirted with this in some contexts, like with home patients and things like that, supplies, but it always came down to whether or not you were going to stick to the rules that we made because of there was pushback from physicians. So you had an override process, and did you have something in place to sort of monitor like the level of overrides that was occurring up front and like having minimize that?
No, and we did have a lot of trouble. It took us literally years. I didn't say this, but it was probably like 35 or 38 sites or something like that. It took us a couple of years to get there. But it was just the experience. It was like sort of unblinded data that clinics weren't ready for. But they would just look at the others, and if they weren't doing as well as other clinics, you'd say, well, why not? And you'd say, well, we're not doing that. And you'd see the scores going up when we started doing this, and the patients would come in. It's sort of like evidence-based medicine in a sense. You get enough places trying it and saying, it really works. And we had the leaders of the clinics come together and talk about what they were each doing. And so it spread. So we didn't have to be too heavy about it. And the measure, we had refill nurses in most of our clinics. Just ask them.
We've been working a lot at adherence. And one of the issues is, it is kind of this thing, I'm not so sure making them come back is a critical step to keeping the heart attack and stroke away. I think keeping them on the meds is a critical step to keeping heart attacks and strokes away. And it depends on what you're measuring. Because inside, if you're doing HEDIS measures and you're measuring blood pressure and lipids, then you absolutely have to get them back, right? But if you believe that the medication, being on the medication, is beneficial, as there's a lot of data, and we start looking at adherence, and we're trying to push our adherence up, then coming in wasn't as important as doing everything we can to keep them on the meds. So I'm just not so sure that the coming in of everything you said, I applaud what you've done. It's fabulous. And getting them in is good too.
If it's not right, then, there's not enough evidence for this. There's no papers published. But I can tell you that if you went and asked the 38 lead physicians at the site, is this important? They'd say yeah.
Good. That's fine. And I don't want to get
And this is sort of like I don't know, just randomized controlled studies and there's case series and we're down here somewhere.
Which is valuable.
Yeah,
Thank you.
You should publish it, because one of the issues, I'm a cardiologist, and almost everything we do has a randomized clinical trial of 10,000 patients or more. So, one of the questions that's always asked is, how often do patients with a chronic disease have to come in for reevaluation? Zero data out here that I'm aware of. And for hypertension, for diabetes, and so I could see us going to a university faculty and saying, this is what you have to do. And the first question they're going to say is, show me the evidence that this is mandatory.
Well, I'm kind of interested in what Jim said because, and wonder if you have any impressions or opinions of the content that was going on during this visit, to try to separate out the visit from the content. Was it the knowledge that was being transferred, and could that be transferred in another method or another setting, or was it the FaceTime with the doctor? I'm sure you don't know, but I'd love to know what
But
the
I
secret sauce
can't
is.
tell you that not every visit is equally valuable to patients. And we know this from chart reviews. I'll talk about them in a minute, but we know this from chart reviews. Patients would walk in and then walk out, and they wouldn't be much better for it. And Jim, actually, I have a better answer for you. I think you're right. I can tell you, I think that this worked for us because we weren't sophisticated enough to do anything else. So you are right. If we had a way of tracking patients and keeping track of who was last tested, and in our new world with the Clinical Care Organization, medical homes, maybe it's just going to be a phone call or something. So you're right.
Well,
keeping them on the
I don't think I'm right particularly. I think both ways are really valuable.
I think they're not incompatible.
Both
I'd say this
they're
is
not incompatible.
yes. So this is for the less advanced, like we were. This helped us do what you're talking about in a
Keep them on. When you see them, and keep them on.
right.
Just one more data point. Ted and I exchanged some data that was quite interesting about a year ago. And we looked at frequency of visits stratified by A1C. And what we found is that patients with the poor, and it probably makes perfect sense, but patients with the poorest control came in the least. And the patients with the best control came in the most often per year. So in other words, we were seeing those patients in good control. They probably didn't need this, but the ones you may have caught were those ones that were in poor control, and at least according to both of our systems data, didn't come in.
I think there are other papers too. I don't know if there's RCTs on number of visits, but there's enough observation data to suggest that higher visits correlates with better control. Correlates. And I think it's a positive thing. You know how when we started sort of getting patients back in is when we started doing chart reviews of patients that were admitted to the hospital that had heart attacks and were diabetic. And then you'd find these stories of them kind of drifting along, and then they got refills and encouraged to adhere to diet and exercise, 12 months of refills, they're in for an ankle sprain, and the PA encouraged follow-up with PCP, and unfortunately it didn't happen soon enough for his heart attack. So anyway, that's just an idea. All these are just ideas.
Bruce, quick question. Intuitively, better control should be more cost-effective care. Did anybody take a stab at looking at the cost side of all of this? In terms of how much money, given the pressure that the healthcare system's under, how much money can actually be saved by getting better control?
There's a couple of papers out there. Maybe you're going to,
Well, I was just going to say that, oh, go ahead. I mean,
It's a debate, and as far as case management, the whole thing about chronic disease management doesn't save money. The simplest way, and this was a government an analysis, actually, I think they did it, but it was for diabetes, maybe. Catastrophic illness, yes. Depression, maybe. What was some of the asthma? Probably. So there's no definitive answer on these things. Most of the ones that says I've seen for diabetes, what doesn't save money? Yes, but only if you include lost days of work. So most of the studies that have looked at this type of problem with diabetes is you can almost make the program pay for itself. There's one 10 years ago in the end, that's case management.
there's just two things. First of all, you have to be incredibly aware of the perspective, so that from the insurance plan perspective, from the provider perspective, so that one might be losing money, one might be making money. So when people say, oh, it's cost effective, I ask, according to whom? But the second thing is cost effective by definition means the bang is worth the buck, not that it saves money. So that almost everything we do in medicine that's cost effective costs money and increases the overall cost of healthcare. Excuse me. So the phrase is oftentimes misleading too. So the goal is not to save money, the goal is to make people better, and we try to do it in an efficient as possible way.
We made most of this run in a fee-for-service environment without a whole lot of extra costs. And from the health plans, we would get paid for performance dollars, which would help supplement some of the quality staff. But most of the things that you'll see here, everything in the office, diabetic educators, all of that pretty much paid for itself, as well as primary care does anywhere. Okay, so we can go. Increase the tempo. This is, yeah, I want to talk about these studies first. We had to get people, we had to increase the tempo, and it's very funny because now I'm in a new environment and the tempo's not there, and I'm really trying to push without pushing, trying to get people there and say, wow, we got to move faster on this. So the first study is from the Lancet, shows that controlling LDL reduced MI, stroke, and death within the first year by 10 to 15%. So it starts paying off right away. So you don't have the luxury of diet encouraged, come back in 3 months.
That's not in the primary care population, right?
No, actually, that's just one representative one. There's a number of studies that show multiple risk factor control starts paying off. Actually, they're the cardiologists.
Yeah, no, I think those, it does. I don't disagree a bit. There's a difference if you're dealing with people who already have manifest disease and/or symptoms, and pure primary prevention, which is to put it in the water.
Yeah, you know, that's really good. And I don't remember if they did multiple risk factor intervention trials, not actually in this one. I'm not sure any of them that looked at diabetic patients pre-established vascular disease diagnosis. But the idea is, I think there's a preponderance of evidence that, especially for LDL, you know, you start moving on that faster and the payoff. I was just diabetics. This, actually, I think you're right, the first one, I think it was established coronary vascular disease. I think you're right about that. But anyway, that's just one of the studies. But I think there's sort of a preponderance of the evidence that for LDL, lower is better, and the sooner you get started, you know, the sooner it pays off. Another study by Yamal in the American Journal of Public Health, that was a FEMA study everyone talks about, that you'd have to, just to do the preventive care, you'd have to spend, you know, 8 or 10 hours a day, not even take care of it, just do the preventive care sometimes a year, because they take much more time than you actually allow. More appointments does correlate with better glycemic control. There's one by Pat O'Connor there that says that. So by getting the evidence out there, that was part of the way we got clinicians to start increasing the tempo, but it's very, very hard. Increasing the tempo, scheduling planned diabetes visits, and I love this because I was talking with one of the groups about this idea. It's a group of, I don't know, 12 doctors or something like that, and it was always going to push back, oh, well, it's all about the numbers, and they won't come in, and how do you expect? They have 4 or 5 problems, and how can we do all this? And I said, well, that first was actually from Health Partners, not in Minnesota. I said, well, you know what, Health Partners, they have planned diabetes visits. Yeah, there's like 5 or 7 things you should be doing, and there's really too much to do that, and there's pressure and everything else. So it's other groups start having planned diabetes visits. You get better care. It's funny because one of the doctors is most energized about this. Said something in words that were slightly nicer. Well, that's the first intelligent thing I've heard all hour. It was the idea that, of course, this is very, very important. There's too much to do. I'm an internist, and I don't know how many people here are practicing, but there's just too much to do. You can't do it all. And to think you can is just to set yourself up feeling bad, or the patient not getting what they need. Scheduling follow-up in 4 to 6 weeks of not control. You know, we really push this. Get them control. Explain to the patient. You're going to have a few visits. We're going to be working together closely for the next couple of months, because once we get this control, you know, your risk of heart attack, stroke, and death goes down, down, down. And we tell patients that, and they say, well, what about the copays? You just want the copay. We had to train the staff, because it wasn't me that they said, you just want the copay. Because when they're walking up to the copay. So we have to train the staff in this. Other ideas to increase the tempo, it is not necessary to have an A1C change medications. And that, it just was our habit. They come back in 3 months, we get another A1C, and then we'll decide. Come back in 3 months, get another A1C, and then we'll decide. And it was a culture change to say, no, fasting blood pressure is consistently over 130. They need more medicine. They just do. And so don't deny them. Self-titrating insulin is another one. Not everyone used this, but quite a few people started using it, especially with Lantus. And just start them on 10 of Lantus a day and say, okay, now, after you're on this for a couple of days, I want you to start increasing 2 units every 3 days until your FPS is consistently less than 130. Some patients can do it, some can't. Some doctors would do it, some would help some people. Use certified diabetic educators, and that gets this whole slide later on. But one thing to note is that most health plans Medicare are paying for them now, and so you could put a visit with them in between your own visits to get the tempo off for the patients. Ordering a direct LDL is sort of another big breakthrough for us. Patients, you'd say, hey, you need a fasting lipid profile. They wouldn't come back. It would be 3 months later. And then I tell them again, they forget again, and that sort of thing. So we started ordering direct LDLs. Does anyone do that? Direct LDL? Is that, oh, this is going to hold loose? Okay.
I'm confused, and I shouldn't be. I didn't think that the fasting affected the direct LDL versus the normal LDL, because the non-fasting LDL is for people whose triglycerides are really high, and it messes up the calculated LDL. But if your triglycerides are normal, then I didn't think there was a difference between the fasting and the calculated. The direct and the calculated.
It's not, but if your triglycerides are a little bit elevated, yeah, I don't know, maybe we should just be using fasting lipid, we should just use lipid profiles all the time. But it just takes that extra part of calculating. The direct LDL is cheaper, and it gets right what yours. So you don't have to worry if there's, in other words, it's more accurate. So it's more accurate and cheaper. And
we see discrepancies. A lot of our docs order the fasting lipid panel and direct LDL because we told them we want them to do the direct LDL. And the LDLs are often very different, the calculated versus the direct. So I agree. I think we had looked up some data that the direct, from what we saw, was more accurate. So that's what we're running our reports off of. But it's funny, our docs are ordering both, because they want to see the triglycerides too, so they've always ordered an FLP.
I hear tell that the next ATP guidelines, maybe Ted knows, are you on this ATP guideline committee?
No.
Is going to recommend non-HDL cholesterol instead of LDL. So everything's going to change a bit.
so for the meantime, this works pretty well. Most insurance plans use an edit, and they won't pay for the direct LDL and the lipid again at the same time, unless the triglycerides are elevated. So we've been running studies. This got us a lot of, this helped us a lot. Once we got the staff sort of scripted or choreographed into creating a little workflow around what we're doing. Starting with the pre-visit, in some clinics, few, but some clinics, they'd have their staff look at the schedules, 10 days out, find the diabetics, and then make sure they had all their testing done before the visit. Some did that. Most, it would happen during the rooming procedure, so we had rooming standards. So the medical assistant would check and see if the patient is due for labs and alert the physician to order them or order them directly. Once we got on the electronic medical record and had order entry, they could just put it in and be signed later. Order point of care A1C prior to seeing the physician. There's a paper out there that showed, and this was a randomized controlled trial, that if the physician had the A1C at the office visit, he or she was 40% more likely to make a medication change. So we started putting them in our clinics, and it was hard working all the bugs out to slow things down and all that sort of stuff. But every time the patient came in who was overdue for one of these, the medical assistant would grab the patient, make sure they had an A1C, and that was part of what would get addressed during the visit. It didn't matter if they were there for back pain, or if it was your patient, or it wasn't, or whatever. They got that taken care of. That took a lot of work. I thought it was I thought it was pretty helpful. I'd have to say that others thought it was very helpful. If you ask our diabetic educators, the group, and the quality people working on this, they thought this was very, very important. I thought it was just very, I thought it was helpful. Check blood pressure according to standards. This is for the medical assistant. Alert the physician if above target. We actually would have the medical assistant go through evaluations, and they would have to check blood pressures and things like that. Because we kept hearing, oh, they do a terrible job, they did a terrible job, and some of them did do a terrible job. So we had to retrain them all for them to do it. Same with about terminal digit preference. So that is, you think with the blood pressure cuff, it'd be sort of random distribution of blood pressures ending in 2, 4, 6, 8, and 0. But there's not. About 60% end in 0. And, so it's because the nurses, the medical assistants would just take blood pressure like that. So we had to teach them about that and teach them about being exact with their blood pressures. Oh, and shoes off. I don't know if anyone else doing this. I thought that was really helpful because, you look at their feet, you document it, which is probably a good thing, but sort of somehow this cue to the patients and to the doctor that this diabetic patient and, you should be doing this. Written instructions for the patients. I thought this was very important. Other people thought it was just helpful. Two studies I have that you can't really see say that basically the minute the patient walks out of the office, they can't remember half of what you told them. And there's 3 different studies asking that question 3 different ways. They can't remember half. So the plan is that we would give them an after-visit summary in EPIC, or even before that, we do a printed report card of their results. And then you come schedule their follow-up appointments before they left. So that was, I thought that was pretty helpful. This, you can't really see it, but just get the idea that before we went electronic, we had a paper copy that would have the goal and have what the patient is at. And that report card, the nurses, the medical assistants said it would really have a lot of impact on patients, at least from what they could see. Patients would be, wow, I'm not there, I'm not in control of what have you. You saw that roster that you couldn't really see. It had a doctor's name and each of the doctor's patients and what their last values were in the LDL and blood pressure and all that in the last visit date. So we taught the medical assistants to work that roster. So they'd look and find out anyone that was overdue for a visit, call them, have them get their visits, have them get their labs, and then schedule a visit when they had them on the phone to get them back in. They would do that for anyone that was more than 6 months out if they hadn't been for a visit, or if it was more than 3 months and they were out of control, and then they were taught to just get that patient back in again. We had to script them for this too, because it's just, Dr. McCarthy wants you to come in. Why does he want me to come in? I just saw him. I don't know. He just told me to call you. That's where we started. He just wants your copay, I think. I don't know, man.
Yeah.
So we had to script it. We had to teach them what we were teaching everyone else. He says, you know what? Dr. McCarthy makes a big deal about the diabetes that control because it's so important for your health. It reduces your risk of heart attack and strokes and that sort of thing. It's something advanced. But we teach them those words and we haven't practiced those words because they just called up willingly. And this was hard to get done. To get the medical assistants actually take these rosters and do something with it. Very, very hard. It took months and months. Again, we started with clinics that were sort of the most organized, that had the best leadership, that showed that it really worked, and they could have spread out through there by having those clinics tell the stories with other clinics. And that's how we were able to get people on board. But once a clinic committed to this, it was the manager's job to make sure the medical assistant really did it. It had to, because otherwise it was too much work, otherwise it would die if they were checked.
So I ask a question, so interesting, so you have the medical assistants on the list, basically, work on pretty sure the docs, which makes sense, they know the patients see them, and then, so there's one medical assistant working with the doc, and not 2. And my question is, when do they have time to do that?
Well, we got that question a lot,
Yeah.
and what we said is, in the beginning, just work a couple of weeks. Don't knock yourself out. Just get a couple more patients back in.
But some of the docs probably would have like 40 or 50 patients on the list or more.
Yeah, the typical family physician would have 40 to 60.
Yeah.
Someone who's full-time in insurance would probably have 90 to 100. And some that have been there a long time, very busy, might have 180.
How often do you run the lists? So they, I mean, so at first did you see that they wouldn't even get through the list?
Oh yeah, I've had to be told not to. Just do a few and sit down with the doctor, because the doc, I mean, we would know. No, I just saw, no, she's not, no, she's got cancer, forget her, you know, whatever. And they say, hey, we put it, I'd like you to call these guys. And so that's how my medical assistant would come to me and say, you know, here's the list, here's who I call automatically, you know, and, you know, is there anything else we should do? So it was, and that was a scary thing about they have too much to do already, and how on earth are you going to do it? And we did all this and more, partly just by, it's like a garden. You know, if you think about a garden that's never been weeded, and you go, oh my God, I've got to do this continue all day. But once it's weeded once, they just go through and pluck out a few weeds.
Can I ask about access issues?
Yeah.
And whether or not you have issues cropped up with, you know, patients being called in more often than they have been coming? Did you have people who were willing to open spots on their schedule? Did you open spots up on their schedule? Was the volume kind of trickling over time so it didn't really cause a big
The volume wasn't so big, number one, and we had instituted open access or advanced access.
Okay.
And most people, everyone there was paid in productivity, so visits were good.
Okay.
And
I know that's an issue with a lot of places. If you'll implement quality improvements without commensurate change in access policies, and then you've got a bunch of patients on the phone saying, you know, I'd love to come in, but you can't see me until 2 months from now.
so the open access was big. And that was, and actually we got more, we're trying to get work off of those. I know we're going in the other direction now, but we were on fee for service. That's how we got paid by the insurance companies, and that's how the docs got paid. And so, you know, we try to bring patients in for everything. That's the truth. Sweet to say it, but it's really more. Anyway, this is the roster. Again, that's what the medical assistant would do. Certified diabetic educators, using them to their fullest potential. This was huge for us. This was huge. And now with the changes in Medicare and things like that, they could pretty much break even. You don't have to lose money on your CDEs. But we'd have them, we had standing orders, so not only would they just do like education about what they should and shouldn't eat, they could advance the medications for the patients. So they would titrate up insulin doses. They could take the next step on medications that they were already on. Eventually we got we never got to this place where they could start medicines. It just got too complex to create a standing order with the algorithm. Instead they would just sort of email or message back in the system and ask, can I start this patient on Vita or something like that?
But they had blood pressure that if the patient was on those meds, they could titrate them up.
They titrated up the diabetes medicines, but they learned more and more over time. This was a breakthrough about cholesterol management. So I got one patient back, and he came back and said, the CDE was, she's really excited. She said, you've got to get my triglycerides down. Okay, it's only, 380, work on the other stuff first, But that's where they were. They would make recommendations. And the blood pressure, they were just beginning to get. And what they would do is they'd recommend coming back. They would not titrate that. That's, I think, the future of medical homes and all that. We were there yet. Advising physicians on treatment changes. They absolutely did that. We had them meet with the doctor at the doctor meeting so that they would get to know their CDE, so there's a relationship, so they could, so they could share and trust each other, and that was very important to make that relationship work. Oh, and they would activate patients. I guess that's what the CDE was doing with my patient, kind of activating him to go back and, advocate for himself. This is the part, and so that's, other people have done that. The biggest breakthrough for us was getting CDEs. We hired 2 of them, we were pretty large, that were just there to help change physician practice patterns. They would go in, they would read the charts, and they would go over the charts with the doctor and say, this one, you could increase the tempo. This one, you're adding a third oral agent, but their A1C is 10. It's not going to work. Not going to here. I would suggest changing to Lantus or something else. And the CDE also works with that doctor's medical assistant, and that's who did the scripting and training for the medical assistant for why this was important and how to get the patients in. And what do you say when the medical assistant, when the patient says, I don't want to come in, that sort of thing. So this was very, very important. And this really, really helped, I wish Ed was still here, to get the focus off the numbers and on the patients. Because then you're not talking about a number, you're saying, you know, have you worked with the CDE? Does he or she have anything to suggest? There were a couple of physicians who couldn't do this. They were, and you characterize them as the nice guys. And they couldn't do it. They couldn't get the patients to change or hear or what have you. So believe it or not, we even had the CDEs, these two kind of roving ones, work with some of those doctors and then see the patient with the doctor, believe it or not. And one of them saw the patient before the doctor, and then she came out and she said, okay, she's ready to start Lantus and Simvastatin. What? How did you get that to happen? I just told her the truth. But these two they had different styles. One was kind of assertive, and and it was funny because she changed him. He was never great. He was now open enrollment.
Did CDEs ever document in the medical record directly? So they have their own notes as part of the record?
Yeah, they definitely did.
That is a whole other accountability.
Yeah, it definitely did. You know what I'm thinking about is I don't really remember him very much because I don't think I read him very much.
Okay.
Just being honest with you, because you know sometimes nursing notes can be like tons and tons and tons of stuff and you can't figure out what to take from it.
That's fascinating. Yeah. It's fascinating that you had them do a code visit. I've never heard that before. That's really cool. Did you get some physician pushback? Because I'm wondering about, primary care doctors saying, hey, this nurse is not anything.
Like I said, we only did this just a few times. It was for these doctors that just couldn't do it.
Yeah, no.
And they asked for it. So they were in a position where so far behind was so different than their peers that, it was like, here's a resource.
So instead of saying, I'm going to send this nurse over to see these patients with you, we say, hey, I've got this person might help you, do you want it? Is that kind of thing? Is that what you do?
And you'd say, don't take my word for it. Call Joe and Faribault. He used to. They love it. Call them.
Thanks.
That's how we got it. And that was it. Sort of funny to sort of, I don't know how to describe it, sort of forceful and supportive at the same time. You always kept pushing, but always by bringing the resources. Oh, great. Free, practical, and pragmatic CME programs. This was important. And this is sort of a watershed event actually. We had something called a clinical practice council where there's very busy respected clinicians who sat and sort of decided on policy and standards for the group. And big debate went on for a couple of meetings. Should we require the low performers to attend some mandatory CME? And where they landed is, yeah, it seems fair